up. Okay, guys, I apologize for the little bit of delay. I could not get my screen to where the point was where I could get this particular slide. I had 2 or 3 PowerPoints open, and so it was a little difficult there. So the first thing I'm going to do is I'm going to pull up and go over the exam, the last 4 questions that we covered, or that was on your little test. And Marissa, I think I just sent you, I'll be sending you the post test, but I think you've got the questions on the ones from that's going to be put up for today, if I'm not mistaken. So let's see, let me pull up these questions, guys, and then we'll go from there. So the last few questions that you guys had were, here we go. All right, so yesterday's questions we left you with the first question was, Brady, I think they're all going to be posted in Moodle after the fact, so that shouldn't be a problem. I think that's what they've been doing. All right, so Saturday afternoon questions. First question, which drug is a proton pump inhibitor? And the questions, answers that were available were propanthyline, sucralfate, omeprazole, and ranitidine. And the correct answer is omeprazole. Remember, propanthyline was an anticholinergic. Sucralfate was the sort of the Band-Aid type drug I talked about that formed the coating. And ranitidine was a H2 blocker. All right, and then question number 6, which drug binds to TNF-alpha? You had omeprazole, cimetidine, metoclopramide, infliximab, which is Remicade, which the correct answer is D. Omeprazole is a proton pump inhibitor. Cimetidine is a H2 blocker. Metoclopramide was a dopamine antagonist that is used for gastroparesis. And then question number 7 or 3 in the afternoon was, which of the following is the Motilin agonist? You had metoclopramide, acetylcholine, erythromycin, and famotidine. The correct answer was erythromycin. That is the only Motilin agonist that we have. Metoclopramide, as I just told you, can be used for gastroparesis, will stimulate GI activity. Acetylcholine will, but we don't use it much as a drug anyway. It's a cholinergic agonist stimulating muscarinic receptors, as well as nicotinic. And famotidine is an H2 blocker. And then finally, the last question was bismuth acts as an antimicrobial agent. True or false? The correct answer is A. Remember, bismuth is in Pepto-Bismol, and in addition to some of its other actions, it does have some antimicrobial activity. Okay. All right. So we got what we're going to cover today. We're going to finish up on thyroid, which should not take us but just a few minutes. We're going to focus on hyperthyroidism. And then we're going to move to drugs used to treat diabetes. And then following that, we're going to move to drugs that are used as anticonvulsants. And so we will cover that. Our schedule will be pretty much like we've used previously, which will be we will this morning right before lunch, we'll take our regular break, but right before lunch we'll put up 4 questions this morning, give you time to do those before you shoot for lunch. And then this afternoon about 3 o'clock, what we'll do is we'll do the 4 questions, and then we'll finish up with the 10-question post-test. That'll be finished up. We'll give you that about 6, right about at, I'm saying 6:30, that's my time, which will be right around 3:30. So probably about roughly 45 minutes to an hour before the end of the course, we'll give you the last 4. Okay? And Marissa, I'll send the post-test to you. I thought I had sent it, but at the next break, I've got it, and I'll shoot it to you there. Okay? All right. So we talked about hypothyroidism yesterday, and probably the number one agent that everybody uses is levothyroxine, although there's a number of drugs that are out there. And so let's talk about hyperthyroidism. So here we have an overactive thyroid gland. The most common cause of it is going to be Graves' disease. So it is also considered an autoimmune type system, where we have autoantibodies, which are simply, the autoantibodies are simply where your body is generating antibodies on its own. And what they do is these autoantibodies actually attack the thyroid membrane receptors, and that sends a signal for the thyroid to overproduce. So the membrane receptors, it's sort of like when they get attacked, it's sort of like the situation where we've got to, thyroid's not putting out enough, and so we have to do that. So Graves' disease is hyperthyroidism. Hashimoto's disease is hypothyroidism. The other thing we can have is what we call a toxic nodular goiter. The goiter is the swelling in the neck, and what's happening is there's an increase in thyroid tissue, and basically what will happen is the increased tissue then is producing more thyroid. So the way we treat it is we really have really 2 major things, but there's sort of a subcategory. So one is surgery. One aspect is we go in and just, if it's a tumor or something like that, surgically go in and remove it. If we remove too much, the person becomes hypothyroidism, but that's usually not too much of a concern because we can effectively treat the hypothyroidism with drugs. Another way is we take advantage of the fact that the thyroid gland sequesters iodine. So as a result of that, what we do is we give radioactive iodine, and what literally occurs is that the thyroid gland will sequester the radioactive iodine into the gland, and then the radiation is sort of localized and basically destroys some of the thyroid tissue. The third thing, which is what we normally start off with, is typically using drugs that we consider anti-thyroid drugs. And we've got a couple of those that work pretty well. So there's a couple of ways that we can do this, is that the anti-thyroid drugs, basically we can see what happens here is that we've got drugs that actually inhibit the formation of the organic iodine. So a drug like propylthiouracil, another drug is methimazole. Another attack that we can take is that we can inhibit iodide transport. So it's not being transported where it can't be, so it can be incorporated. And we use perchlorate and thiocyanate to do that. And then the iodide, which is basically the radioactive iodine. So let's start with the thiouracils. So what happened, the nice thing about these drugs is that they get concentrated in the thyroid. And what they do is that, remember that we have to, that the thyroid gland has to incorporate the iodine, and that iodination occurs in thyroglobulin, which is in these in the thyroid gland cells itself. So what we see is that in this particular class of drugs, they actually inhibit this mechanism of peroxidase catalyzed iodination. So they prevent the iodination of the thyroglobulin. At a high enough dose, basically we can completely shut down thyroid hormone formation. So in essence, it's almost like a chemical thyroidectomy. Methimazole is and propylthiouracil are the two agents. We do see that methimazole is much more potent than propylthiouracil. And but the thing is, it's going to take several weeks. This is not one of those things where you just go in and you do a week or two of therapy and it's done. Takes several weeks for this to occur because your body's still taking things in and everything, and you have to take care of it. So we see that the propylthiouracil gets protein bound about 75%. It's not up in that close to 90%. And methimazole has a little protein binding, so propylthiouracil is much more protein bound. Propylthiouracil won't go across the placenta as much, probably because of the protein binding. And we see that so these drugs can work, but again, there's some issues. With the thiouracils, what we have is that this is what is probably the most common drug therapy that we see used. The problem is that when we remove the drug, there is probably 60 to 50 to 60% of the patients will go back to their hyperthyroid state. What we're really seeing is these drugs probably are forming or producing an immunosuppressive action, and that may be why that it's important for treating these diseases, since it's an immune suppressant. It also makes sense that since these may be immunosuppressive, when you take away the immune suppression of these drugs, then basically the person reverts back to the to Graves' disease. So it's one of those things where that these drugs will work. Sometimes the surgeon may decide to just go ahead and remove the thyroid again, because they can be sure that it's gone, especially if it looks like it's a cancer or maybe extremely cancerous. But these other drugs can use, but again, it's going to take a little while for this to occur. Now, as I said, as iodine is, we find that if someone takes a large amount of iodine, it will shut down hormone release. It just basically, you have a negative feedback that shuts it down. So people can give large doses of iodine, and that will decrease hormone synthesis. This type of therapy really doesn't work really well for long-term treatment. It's generally what you're doing is that you may be using this short-term treatment. What they tend to do for a long-term thing is use the radio-labeled iodine, basically because when you're giving the iodide and it's not radioactive, then basically you're just doing a biochemical suppression. When you as soon as you lower the dose of the iodide, basically what happens is the disease comes back. If you use the radioactive, then basically you're destroying the tissue, and that's a more permanent effect there. Another drug that's been used is perchlorate. It inhibits the ability of the thyroid gland to concentrate iodine, and so that's one of the things that can occur. The problem is that this drug can produce aplastic anemia, and the aplastic anemia can be a very big concern. Remember from when we talked about anemia, is aplastic anemia. Basically, what's happening is your body is not going to be able to basically produce white blood cells, red blood cells, or platelets. And as a result of that, this can be, this can be one of the major concerns with this drug, is that the side effects may be worse than the treatment or than the disease itself. And so that is one of the things that was used. Now, we don't see this drug used very much at all because of this, but it was one of the other mechanisms. But again, the side effects pretty much have eliminated it. So what we see with hyperthyroidism is typically we see the thiouracils, which is either propylthiouracil or methimazole, or we see radioactive iodine used for long-term treatment. We see these used, or we use surgery. And again, there's not too much of a concern that if you end up going to the other side of the spectrum, where that the person becomes hypothyroid, that is really not too much of a concern because we can treat that. This last slide sort of just puts everything together visually, and it shows the where perchlorate will actually work is over here. And then it shows the different mechanisms of this in the follicular cell. So it's just really demonstrated where chlorate uses. But again, what we tend to see is the propylthiouracil or the other drug, methimazole, being used more frequently, simply from a standpoint of that is what they consider. But again, you're taking that, if the person is still hypothyroid, when you remove it, it's going to come back. So that's one of the big concerns that we have there. So that's why for a more permanent thing, people often opt for the radiated iodine or the surgery. Now, one of the cautions with the surgeries actually comes down to is they have to be very careful, because even a careful surgeon can sometimes take out the parathyroid gland. And so if that occurs, then we develop hypoparathyroidism, which can affect bone and calcium. And that we'll talk about treatment of that when we talk about hormones the next time we meet. Okay. So just to summarize before we move on to the next, when we talk about thyroid function, it's a pretty negative feedback. One of the things is you don't, make sure you're going to have people that sometimes you'll run into that are going to want to use thyroid hormones to lose weight, or may ask you for a prescription for levothyroxine to lose weight. That is a black box warning about that. You don't want that. But typically what we see is Hashimoto's basically produces the hypothyroidism. And what we're going to do is most of the time we're going to use levothyroxine. Levothyroxine is going to be, we're able to replace it. We're able to do pretty well. The biggest thing we have to be concerned about with levothyroxine is that, people can take too much of it. So we've had a few errors when people are writing prescription, or that they've been filled, where that the wrong dose has been filled, and it's created some problems from actually producing, too much of a thyroid issue. So we want to monitor these patients. We want to treat them. And again, levothyroxine seems to be the preferred. Liothyrin is basically used for the emergency if somebody was going into myxedema coma. But the other preparations typically are either synthetic or derivatives of porcine, primarily porcine thyroid hormone. And the organic preps and so forth, there's a lot of variability in those preps. There is a lot of question about what's in those preps sometimes. So that's one of the things we always try to avoid against. But some people say, can start getting this powdered porcine, and that may be something if you have somebody that is, having some weird things with their thyroid. One of the things you want to make sure is that they're not taking a supplement to try to lose weight or to increase their energy from buying over the internet. Okay. All right. So let's see if I can move to the next set of slides without losing you guys. I may lose you for a moment, which I did as far as the screen share. And let's see. All right, here we go. All right, let's see. Let's go here. And there we go. All right, let me get to the beginning of this series here and we can start. Okay, so everybody able to see that? Okay. All right, so now we're going to talk about a big concern. In fact, one of the big things in the news lately has been a shortage of insulin. And we do see that one of the things that we are running into is with insulin is that there is a lot of, we see more people that are, we are seeing more diabetics. Several of these diabetics are not insulin dependent diabetics. They're actually insulin independent diabetics. And so they're making insulin, but they may not be making enough. The insulin dependent diabetics, basically what we're dealing with is those individuals are not able to make insulin. So what we see when people develop diabetes later in life, that is generally where that we have, it is considered insulin independent. So let's take a look at some of these aspects of diabetes. So first of all, realize that we have a diabetes insipidus. We will talk about this next time we meet because we're going to be talking about some of the central hormones. Diabetes insipidus is where that there is a deficiency of the antidiuretic hormone, okay, in your brain. It's called vasopressin, also ADH. And basically what happens is when you have a deficiency of that is that you're losing a lot of water. All right, so we get large quantities of urine, and so that is a different treatment than what we're dealing with. Most of the time when people are talking about diabetes, we're talking about diabetes mellitus, okay? So diabetes mellitus, we see large quantities of urine also, but the urine is considered sweet because it has a lot of glucose in it. And what's happening is because you have a deficiency of insulin or that the insulin is not able to work, we have maybe what is called insulin resistance. What's happening is that the insulin is not able to drive the glucose into the tissues. So as a result of that, the insulin stays in the blood and then it spills over into the urine. And when the glucose goes into the urine, it can form an osmotic diuresis. Large quantities of glucose that's in the urine will pull water into the urine. And so as a result of that, we get the diuresis. The other thing that happens is, since most individuals that are having this problem have a difficulty in metabolizing fats, they produce ketones, and the ketones actually get excreted through the urine, and those can also contribute to the diuresis. We see that it's estimated that probably, and most of my comments the rest of the day on diabetes is not going to be dealing with diabetes insipidus, okay? So we're going to be focusing on diabetes mellitus. Estimated that probably 3% of the population has diabetes. Most people probably feel like that's an underestimation. There's probably more people that have it. There is this widespread perception that diabetes basically is cured by giving people insulin. Some people that are diagnosed with diabetes think that, okay, my disease will be cured because they're going to give me insulin that's going to take care of it. But we find a lot of that it's a chronic disease, and being a chronic disease, we find that more people are less likely to pay attention. We see more people are more likely to quit taking their medication or not pay attention to taking it correctly. Especially those people that are, that have insulin independent diabetes. We do see a lot of complications associated with diabetes. And in fact, we do see that these complications account for, is one of the leading causes of blindness, renal failure, cardiovascular disease, which includes heart attacks, which includes blood pressure and so forth, and limb amputations. And when I say limb amputations, legs, feet, toes, fingers, those occur there, and then that occurred. Let me check something, Jason, that you just brought about. I'm gonna, let's see. Yep, you're right. Let me take a moment. I'm glad you caught that, Jason. I think the slides are, the verbiage is there, but let me swap to the red slides that I gave you. So guys, just give me a moment. So the red will help me to emphasize to you guys which points to look at. All right, so give me a second here. Okay, maybe this is a lot better here. So just to make sure that we are there. So this should be, as I said, as I think that the, yeah, so this is the red. So again, the reason I wanted to switch that, because typically the slides are there. I've just gone back and made the red version so that you guys know that, you know, what's important. And, but sometimes in going through, I have deleted some of those. In fact, I deleted some of the slides, I think, with their prior to that. Okay. So when we're looking at this, is these complications, that's why it's very important. A lot of these individuals, basically, what happens here is that the if it's untreated, we see a lot of problems associated, and specifically cardiovascular disease, renal failure, these type of things. And when these things occur, can make your job a lot harder, because now you have a patient with many more problems. In addition to that, you've got a patient that is maybe having mental issues dealing with these things, losing their sight, or so forth. So that does create problems, additional problems. Now, what we're looking at is with diabetes mellitus is pretty much the situation. Jason, thank you for bringing that to my attention. When we're looking at diabetes, the key point here is that the circulating insulin levels decline. So they either drop too low, or, well, actually this can be and or that the target cells that the insulin acts on are become resistant to the insulin. So the insulin is ineffective. So either we don't have enough, and or we have some, but the tissues aren't responding. We refer to that as insulin resistance, and that tends to occur more frequently in insulin-independent diabetics. But either way, what we're seeing is that insulin is not working. Either we don't have enough insulin, and or the insulin that we have is not, the tissues aren't responding to it. So there's two classifications. You guys are aware of this. One is called insulin dependent, which is often abbreviated IDDM, also called juvenile onset diabetes, which is generally going to occur younger, early in life. And then the insulin that most people develop later in life is referred to as non-insulin dependent, or NIDDM, or maturity onset diabetes. Okay. So unless there is, typically this insulin dependent may occur later in life if there's some damage to the pancreas, where the pancreatic beta cells are destroyed and the body can't produce it. That can occur, but typically people that have insulin dependent, it has started when they were much younger. So with IDDM, insulin dependent, is typically there is a degeneration of the pancreatic beta cells. The beta cells, if you remember, basically are the insulin producing cells in the pancreas. There's also alpha cells, but they don't produce insulin. Probably about 15 to 20% of the diabetic cases are insulin dependent. This is considered probably a more serious type of diabetes, because with the insulin resistance, typically there is some degree of response, but with the insulin dependent, then we're not just producing, there's not enough insulin to produce anything. Typically there's a genetic predisposition. So someone in the family has had diabetes. There are some instances or beliefs or evidence that we may have people may have gotten viral infections, and the viral infection could potentially predispose someone by basically attacking or either getting onto the in the pancreatic cells and then causing some damage there. So some people have suggested it's been viral, but we do know if there is a history of diabetes in your family, either side, type 1 or type 2, insulin dependent or insulin independent, is that you are that you're more likely to have diabetes. Typically, we don't really know what causes the pancreatic beta cells to be generated. Some people have suggested that there's an autoimmune disease, but and that's one of the things people sometimes have thought, well, the person may have been exposed to a virus. The virus has affected the beta cells, and then the immune system sees the beta cells as being damaged or dying cells, and so it goes and attacks them. But typically what we're going to see is that the clinical symptoms come on pretty quickly. When the insulin falls below the particular level that's necessary for normal function, the symptoms come on, and we have what is called a triad of symptoms. Typically, these patients will present with polyuria, polydipsia, and polyphagia. So basically what's happening with polyuria is that, as I mentioned earlier today, we are getting a lot of glucose spilling over. Since there's not enough insulin to drive the glucose into the cells where it can be used, it stays out in the blood. And so as it filters, typically what's going to go is that extra glucose will go over into the urine, and then we get that osmotic diuresis. And again, ketone bodies that are formed can also contribute to that. So the polyuria, they start going to the bathroom because the glucose is inducing the diuresis. Okay, so that's one thing. So as they start losing glucose, a couple of things are going to happen. One is they're losing volume, water volume. So to replace that, your body becomes thirsty to make you drink. So that's the polydipsia. And then the other thing is, because you're losing glucose, your body's needing glucose. And so the tissues are saying, I'm not getting enough glucose. So as a result, what's going to happen is that basically the signal for you to eat. So people drink a lot. They are basically eating a lot to try to make up for this glucose, and then the glucose is making them pee a lot. I'm seeing you guys having some sounds from the microphone. My microphone it must be picking up from somewhere else because there's no movement here. But let me just double check my connections just to see if that will help. So see if that is. Okay. Now, and this is what I just went through. So basically, the thirst and hunger is due to the loss of fluid and your inability to use nutrients. You're not getting the glucose because it's going out through your urine. People typically lose weight because they're not able to use the nutrients. And in children, the other thing is that we do see stunted growth because basically, if they can't get the nutrients, then their body can't grow. So what we find is when we start looking, and we can measure insulin levels, one of the things that we see is that basically at the beginning of the onset of this is typically we see the serum insulin levels are there, but they're lower than normal. So we do have a hypoinsulinemia. So basically what's happening is that the pancreatic cells may be making a little bit of insulin, not a whole lot. But what happens is that as the disease progresses, we get to a point where that pretty much you're not making any insulin. So we pick up first that the insulin levels are low, and then as the disease progresses, we find out that they go to basically undetectable levels. So if that continues, and this is we're talking primarily juvenile diabetes or the insulin dependent form, pretty much remember that, for example, your brain almost uses glucose exclusively. It doesn't use fatty acids. So what we find is if the insulin is not supplied, what your body starts doing is it starts trying to break down fats, and we actually develop what is known as a metabolic acidosis. that acidosis can progress fairly rapidly to where someone goes into a coma and can die. So that's, and we see this as a problem with insulin dependent patients now, is that they have to have their insulin. They have to be trained to know when they are, starting to have a crisis develop. So the reason this metabolic acidosis develops actually is that your liver will start synthesizing what is called ketone bodies. So what happens normally, if a person that is normal, that basically, and you're eating well, not fasting or anything like that, what happens is that basically when insulin is present, then one of the things insulin does is it will actually stimulate fatty acid synthesis, okay? If insulin isn't present, then instead of getting fatty acid synthesis, fatty acids, basically what happens is you start synthesizing ketones, and ketones are acidic. And so if insulin's there, we don't synthesize the ketones. The other thing that does is that insulin also will keep lipolysis, keep fats from being broke down, and that will also decrease ketone synthesis. So when insulin is present, the bottom line is we're not going to get these ketones formed, and that's a good thing. But when we don't have insulin, what's happening is the body can't stimulate fatty acid synthesis, and it can't inhibit breakdown of lipids because it needs insulin to do that. So sometimes when people go through fasting states, they can get these ketones type things. So what happens is that when the insulin levels go down, ketones are formed, and and these ketones form in high enough concentrations that, for example, you smell that sweet breath that occurs in a lot of individuals. That's from these ketones. And these ketones, the real problem is that these are acids. These are organic acids. So that's where you get the acidosis. In a normal individual, since we're producing insulin like we normally should, that we've got plenty of insulin to prevent this ketone from forming. So in a normal individual, typically this is not going to occur. In a diabetic individual with no insulin, that sort of opens the gates to allow these ketones to form. The ketones then get in the blood, which drop the blood pH. So now we've developed an acidosis, which can be serious. What you smell in the breath, the sweet breath you smell, is actually acetone, which is like fingernail polish remover. Acetone is what's in fingernail polish remover. And that's one type of ketone body. So that's sort of, it becomes volatilized in the breath and blown out the airway. The other thing that happens is that if not treated, these diabetics will develop dehydration. Think about it, that they're having all of this glucose spill over into the urine, which is pulling fluid out of the body. And when it's pulling it out of the body into the urine, then they excrete it. So one of the things that can happen is they can become extremely dehydrated. The other thing that can happen is one of the ways that your body tries to reduce the acid load. If you think way back when we talked about acid-base balance, when your body is retaining a lot of acid, then one of the things the body does is to induce vomiting. And the reason that's used is because hydrochloric acid in your stomach can contribute to some of the acid production. So one of the ways your body gets rid of acid is to make you throw up your stomach contents, and that's decreasing the hydrochloric acid. So vomiting can cause further depletion, fluid depletion. And so we see that without the insulin, we got a major problem. We got the issue of the nutrients aren't being used, so we have an issue about the body being able to grow, repair, and so forth. We have the brain, which is basically needs glucose, and without insulin, the brain can't use that, can't use the glucose that's taken in. The glucose spills over into the blood. We get a lot of polyuria. So we start losing fluids, and we start increasing the production of ketones, which makes the body more acidic. And the more acidic the body becomes, then the more problems we run into. We get vomiting, we get dehydration. So we have a lot of systems that get shut down because of that. Okay. Now, that's primarily the insulin-dependent diabetes. So that's where that we're not getting any insulin produced by the pancreatic beta cells. Now, non-insulin dependent diabetic mellitus is also comes with a lot of issues. Typically, this doesn't develop till later in life. We typically will see people close to 35 years of age or older that start showing signs of, and that's one of the reasons that when you're younger, we're trying to keep you exercising, we're trying to keep you eating your diet well and so forth, because as you put on weight, one of the things that can happen that sets you up for diabetes. So what happens here is basically the individual is going to be, these non-insulin dependent diabetics basically have insulin. Their beta cells are still making insulin. So typically the insulin, if we measure it, the insulin is at normal levels. Sometimes it may be even slightly above normal, okay? Since we have insulin here, these individuals don't develop the ketosis. They don't develop the ketones because, as I said a few moments ago, the ketones are basically don't form if we have some insulin there. But what seems to be the problem here is the real key here seems to be that what we're dealing with is primarily that we've got a insulin resistance, okay? So the target cells, the things that insulin normally binds to, and this can be due to, in some instances, it may simply be that there's, for some reason, there's no insulin receptors, or the insulin receptors on the target tissues are actually not present. So that can be one of the issues. Another thing may be, and this could be in combination with fewer receptors, another thing that may be is that basically that the receptor transduction pathway, which downstream from the receptor, some problem there. But what seems to happen is that the individuals produce the insulin, but for some reason, the tissues are just not responsive to insulin. One of the things is, in these patients, fortunately, we rarely see diabetic coma. Diabetic coma is typically produced due to the ketone bodies and the acidosis. So we don't see a diabetic coma that occurs here because they typically have enough insulin to produce or to keep ketones from forming. But we do see what is referred to as a hyperosmolar coma. And this we see more commonly in the elderly. Typically what we've seen is the elder person has diabetes, the non-insulin independent diabetes or non-insulin dependent diabetes, and then they get ill or undergo some sort of stress. Their insulin requirement goes up and they just can't quite meet that. Sometimes if they're ill and been throwing up, this can make some complications. Diabetic coma can be life-threatening. Hyperosmolar coma can be life-threatening. So both can, but the mechanisms are different. So if a person was in a coma and you knew they were diabetic, but you didn't know which type of diabetes they had, the safest thing to do is to give them glucose. I'll come back to that. Because if they're in a coma due to too much insulin, then if you give them more insulin, that can kill them. We'll talk about that in just a few minutes. So let's take a look at insulin. There is a lot of different preparations of insulin out there. This is truly the only drug effective in treating insulin-dependent diabetics. They're not making it. They need it, okay? Now, it's important that these individuals, we have better control. I've told you this before. We talked about pathophysiology, is that it is very difficult to match, even with using pumps and everything else. It is very difficult to match the body's insulin needs. So trying to use pumps, doing injections, and so forth, it's just we can't do as well as the pancreas does, okay? But we do find that typically insulin, what we want to do is to keep their weight down. We want to have them have a moderate exercise program. These type of things increases insulin sensitivity, which means that when we give them insulin, it seems to work better. We have to always be careful about compliance with these patients. Is sometimes they forget, sometimes they just get tired of doing it. We have to be careful. So it's important that we try to keep them on a diet, exercise program. This is important not only for the diabetes, but it's also important for the cardiovascular components. But by keeping their weight down, moderate exercise program, have them take and monitor their glucose and do the things they're supposed to, we can do a lot better job. But again, one of the things is this is a chronic disease. People get tired of doing it. They forget. There's various other things, even though we have a lot of education going over as to why that is important for them to do it. We still see individuals. I'm just curious, any of you that have patients right now that are diabetics, how do you find that they're compliant? Do you find that they are non-compliant? I don't know if any of y'all find that out too much about the patients that you're dealing with. Yep. It's really amazing to me with all the consequences and everything Kirsten, that's a good point there, is that basically some of them is like, I'm feeling fine, so I don't need to take my medicine, or why do I need to do that? Teens, I would agree with that, Danielle, is a lot of the teens don't quite understand. It's sort of that immortal type situation of I'm young and it's not there. And Geraldine, basically with the rural population, sometimes it's like they're not concerned by the diabetes because everybody has it. That's another thing that you run into, Danielle, is exactly that. The teens, I do know that there are some teens that are diabetic, and they can be very self-conscientious about that. I think I've shared with you a lawyer that's been on the other side of me several times, who I have a lot of respect for. He's diabetic, and I mean, I keep telling him he's the most compliant person I've ever seen. He, takes a deposition. He lines jelly beans out in front of him. He stops in the middle of court and does his injections and stuff like that. But we see a lot of variability. A lot of times we run into problems. It's typically with compliance. I've dealt with also some patients that people that I've known that have had amputations, and basically it ends up from we go through a lot of stuff with this one guy basically had to have like 3 of his toes amputated, had terrible infection that set up with that, and was very expensive and didn't have the money to do it. And we were, our church and several people were shuttling around trying to find people to help pay for his bills and stuff like that. And we got him through that, and within less than a year, he was back to eating the his diet was horrible. He had maturity onset diabetes. He didn't have the insulin, but it was just amazing with all he went through and the amputations and everything, and being in the hospital. He was already out of that with the concern with the diet, going back to his old diet and everything. That's it. And Kirsten, another thing is again, gets back to a statement I made earlier, is a lot of people feel like that they can take the meds and that'll cure it. All right, let's see. All right, before we start talking about the different insulins, let's go ahead and take our break here. So let's come back at 15 after the hour, and then I'm going to start talking about the specific insulins here, okay? Okay, guys, we're back, and let's pick up and let's talk about insulin. So there are numerous types of insulin out on the market. Let's talk about basic, what your body pretty much um, produces. So insulin is actually a protein. It's acidic. It's got two polypeptide chains. We call them the alpha and beta chains, and it's derived from what is called proinsulin. So there is a precursor, which is proinsulin. Um, it's enzymatically clipped to form insulin. Where this clipping occurs is proteolysis. That occurs actually in a secretory granule, and what happens is in the secretory granule in the beta cell, pancreatic beta cell, the insulin crystallizes with zinc. So there's a zinc component there. When we give exogenously administered insulin, that's not stored in the granules. So we don't, that's one of the problems is when we give insulin, it's going to be used. It's not going to be like we don't put it and it gets stored in the pancreas and goes from there. Pretty much we give it, it's used, and then we have to give more, which makes it more difficult to, to basically match what we need to match here. So that's an important issue that comes into play and creates one of the problems we have with regard to, it's not going to store. Now we do have some forms of insulin that is longer lasting than others, but it's not going to go into the, we're not replacing the insulin in the secretory granules of the pancreas, and then the pancreas is releasing it. All right. So what insulin's going to do, and this is even for the different products that we have, it's all going to do the same thing. Its main function is primarily to stimulate transport of glucose, and muscle and fat cells are the two biggest cells that we see used. So without insulin, pretty much your glucose that you get in your bloodstream can't go into the cells. So that's why insulin is so important. The insulin doesn't have to enter the cells to produce its effects. It actually acts on the surface there. And then what happens is the insulin that's circulating around in the blood basically gets broken down. The liver is the predominant organ that breaks it down, but there's other tissues that will also decrease it too. So when you look at the normal circumstances when the pancreas releases insulin, it probably it's estimated probably half the insulin released by the pancreas actually gets metabolized before it even gets into the general circulation. So the half-life of insulin is fairly short. It's a natural insulin. It's about 8 minutes. So again, it's designed to be used almost instantaneously or within a very, very short period of time. It doesn't hang around. And when we have situations like that, it's always difficult because your insulin needs will fluctuate depending on the tissue's glucose needs. And so it's very difficult to, anticipate always the exact amount of insulin we can get estimates, and we know that when people undergo certain activities that their insulin level is going to go up. We know that there's a lot of things that will do it. And so we try to do that, but we just can't mimic the same scenario that we see with regard to that we see in the body with the pancreas. So what insulin's going to do is, one, is it's going to decrease the concentration of serum lipids. This is one reason why when we have diabetes and insulin's not working correctly, then what happens is our serum lipids stay elevated. That sets up for atherosclerosis. It stimulates fatty acid synthesis. It increases protein synthesis. So it's necessary for the normal growth and function of our body. And without the insulin, because it's affecting both fat and glucose, it creates a real problem with regard to our tissues being able to function normally, have the energy to function, utilize the nutrients that are there, and repair itself. The effects we see with insulin occur pretty quickly. Like I said, you got a half-life of 8 minutes, so it's not going to wait around to occur. So one of the problems we have with insulin is obviously there is no oral form of this. There's no way that we could take the insulin and basically, give them a pill of insulin. Number one is with the short half-life that would anticipate it would be broken down. Probably never get it past the GI system because in the stomach and in particular, the hydrochloric acid would probably take care of it. So currently, what we find is our insulin preparations have to either be given sub-Q, typically parenterally in that sub-Q, or there is some nasal formulations, so inhaled, absorbed through the nasal passages. Again, oral administration, you would anticipate a drug with a short half-life and it gets broken down so quickly by many organs, including the liver, that it wouldn't survive it. And so what would happen is any dose that we gave would almost be ultimately destroyed before it even got to the small intestine to be absorbed. Even with injections, there is some delayed absorption, and that can vary depending on the size of the insulin. So even by giving it, sub-Q, the insulin's got to go into the tissues, then it's got to go into the subcutaneous fat, then it's got to get into the bloodstream. So there is even a slow level of absorption that occurs with that. Some insulin we will see act quicker than others. Others are more of a sustained release. These are things we've tried to do to basically overcome several of the problems we've had. Typically, when somebody takes, and this will vary between preparations, is that an insulin injection usually is going to kick in about an hour, and varies with individuals, varies with the insulin use, but typically is going to last maybe up to 6 hours. The long-acting preparations, what we've done there is basically we formulated them so that they're suspensions, and those suspensions are designed for a little bit slower absorption and so slower absorption and a lot more prolonged action. These drugs can never be given IV because they really have got a lot of particulate matter in there, and so we can't give them IV. So let's start off with one of the preparations is insulin and protamine. Okay, so insulin is regular insulin, but what they do is they add protamine, and where protamine comes from is basically that is a protein that's isolated from salmon sperm. And this is sometimes this combination is protamine zinc suspension. And so what this does is by this particular preparation is designed so that it slowly dissolves. It's a longer duration of action of about 36 hours. And the problem here is that we have some insulin for over 36 hours, but the duration is actually too long to really get good control. This is being absorbed not as needed, it's being absorbed slowly. So even though we put it in there, it's going to take about 36 hours to go in. So if we start having things before 36 hours, that's going to be difficult. We can't add regular insulin. So sometimes what we try to do is we do a long-acting, and then we use another preparation that we use for more short-acting effects that we may need. But with this one, insulin and protamine, or the protamine zinc insulin, is you can't add regular insulin to it because one of the things that happens is when you add it, the regular insulin will combine with the protamine and then just forms like a depot, so it doesn't kick in as quickly. So that creates a little bit of problem for us. This next one is one that we see is used quite a bit. This is called Humulin or Novolin. This was actually developed to try to overcome the problems with the protamine zinc insulin where you couldn't add some insulin to it. What this one does is called NPH. The NPH stands for the neutral pH, and this one has very, very low concentrations of uncombined protamine, so we don't get a big thing. So we don't get that long duration of action. But basically, this one will kick in about 2 hours and will last for about 24 hours. Another preparation is extended insulin zinc. What we do here is with these extended preparations, we use larger crystals. So we formulate them so that they're large crystals. And think about it, a small crystal, if you took, think about ice. So if you took a big ice cube, it would take it maybe several hours for it to, or take at least several minutes, maybe an hour for it to completely dissolve, depending on the ambient temperature. But if you take crushed ice, the crushed ice is going to dissolve quicker. So it's sort of the same problem, the same principle here is with the extended insulin zinc suspension, we've got these large crystals which are slowly dissolved from the injection site. Basically, sometimes what we run into with the protamine zinc is that we do have individuals that are allergic to the protamine. And so the extended insulin zinc can sometimes be used. Basically, it is very similar to protamine zinc. It just avoids the protamine. Similente is a suspension of small particles. And when you, again, think of ice, is that the reason crushed ice will dissolve, will melt faster is because you've got so many, you've got a larger surface area exposed with all the things. So what with Similente insulin, what's happening here is this is a suspension of very, very small particles. And these small particles present a large surface area, which allows it to dissolve pretty quickly. This is very close to what we see with straight insulin injection. And then with insulin zinc suspension, what we have is 30% Similente and 70% Ultralente. So basically what you've got is different size mixtures. And this basically is very similar to Humulin is what we see. Most insulin extractions that have come from pancreas, basically they harvested the pancreas and basically extracted the insulin from cattle and hogs. Those we see can be associated with allergic reactions. That's why a lot of people have gone to the Humulin and things like that, which avoids these extractions from these from animals. And that's exactly what recombinant human hormone, the Humulin, which I mentioned earlier, is basically is a recombinant form of human insulin. Interestingly, human insulin is very, very, very similar to pig insulin. So what they can do is they can take the porcine insulin and they can convert one position of it. They can take the alanine and convert it to threonine, and it becomes exactly like human insulin. So Humulin is recombinant human hormone. Novolin is basically where they have taken porcine insulin and converted it to the exact human insulin form. So these are different than extracts. These, I mean, this when we're doing this is not an extract that's being done. Is basically we're taking the insulin. When you take an extract, you basically are taking, you're trying to isolate the insulin out of pig or cattle pancreas, and you try to, some of that extracts can have other proteins in it that can create a problem. So as I've said already several times this morning, one of the major problems is trying to deliver the insulin like your pancreas would. And you just can't do it. It's, we've tried a lot of different techniques. People are still trying to come up. The thought was an insulin pump would potentially do this versus somebody taking the injections. They've tried to formulate different of the injectables so that they mimic it, and it just hasn't been able. Our glucose changes more on moment to moment than we see with, like, for example, thyroxine. And it's important that when our insulin concentrations, basically, if they don't decrease when our blood glucose falls, then what's going to happen is basically it's going to keep driving the glucose into the tissues, and we get hypoglycemia. So what people have tried to do is give multiple injections of these short-term insulins. They try to handle the peaks, and then we may use an extended preparation for sort of to maintain a baseline. So that's what we've seen works. The bet is the best we've got that'll work that way. But again, it doesn't come anywhere near what, think about it is when we inject something subcutaneously, there's a lot of variables that affect how quickly it's going to be absorbed. We can't give many of these intravenously. Plus, you don't want somebody walking around having to give an IV every time their insulin is fixing to go. Their insulin changes. So it's just really, really, really difficult. The insulin pretty much used as prescribed is relatively few side effects. The most common effects that people report, and one thing to be aware of, I don't know if any of you have family that's diabetics or, some of you may be diabetic, I don't know. But, a lot of people are afraid of the needles, both for taking the bloods and for, delivering the insulin. We do know that our needle technology has improved drastically. We have a lot of ultra fine needles that are working there and that are not as painful as we thought they were. And so that has helped. And we have also found that we rotate the sites. That helps. We do see that when people are injecting, that multiple injections will end up producing a localized fat accumulation. That's not a real big deal, but it's thing. We do. Some people have some allergic reactions. Our biggest concern is that if they don't match it, that the individual goes into hypoglycemia. So that's our biggest reason. Because you're injecting at the injection site, you're getting a high concentration of insulin there. So that's where you're going to get some changes that occur. And we get usually hypertrophy around where the injection site is. We start getting accumulation of little fats, triglycerides. So that's one of the reasons that people rotate the sites, is to keep from getting these little fat, hypertrophied fat areas, which can over time become more difficult. Also, by rotating the injection site, it's not as bad. But again, our number one concern with insulin typically is that if we give too much, that we end up getting hypoglycemia. So that's a big concern. That's our biggest concern here. It's one of those extensions of the pharmacology that we expect. Okay. Janelle, let me see if I can adjust something a little bit, see if that makes it better. Anybody else? Okay, Jordan, you got sound is good there. Okay. So I just wiggled the cords a little bit just to see. I don't know if it helps or not, but I went ahead and did that. The other thing that we see sometimes is there's sometimes some contaminants in the insulin. Sometimes there's a little bit of glucagon. That used to be more of an issue where we would get fat atrophy, where the area around would not get hypertrophy. But sometimes what we would get is the fat would sort of move away from it, so or decrease or shrink down. So you'd have these little disfigurements there. The newer insulins that we're using are much more purified, so we don't see that near a problem. With allergic reactions, that can always occur. Those that are getting beef insulin tend to be more likely to have an allergic reaction. And the reason for that is because the beef insulin structurally is more different from human than is the pork insulin. Just a minute ago, I showed you Novolin is one of those drugs that basically is really pig insulin that has been modified by one amino acid. So the beef insulin is much more different, and people are more likely to develop a beef or an allergy to beef-derived insulin. But that can easily be remedied by changing them to pork. Many people just now go with a porcine-based insulin if they're not going with the Humulin. So let's look at this hypoglycemia, which is the biggest concern. All right. So what happens here is that if you give too much insulin to a diabetic, then the insulin basically drives the blood sugar, drops the blood sugar, drives the sugar into the tissue. Okay. Now, how does that occur? Several common things. One is a simple situation where that there has been a dosage miscalculation. Whoever is prescribing basically miscalculated the dose that was supposed to be given, and or sometimes the patient may have drawn up the wrong amount of dose or made an error there. They're in a hurry. Maybe they didn't pull the insulin. Maybe they got some air in it. So there can be errors in injecting the hormone, the insulin. One of the big things we see is that people that change their eating patterns and going on a diet or sort of binge eating or things like that can change the need for the insulin and therefore can produce some hypoglycemia. The other thing is if somebody becomes very sedentary, their insulin requirements get reduced. And so their activity and even their diet has changed to the point where they don't need as much insulin. So that can produce the hypoglycemia. So what happens when a person goes into hypoglycemia? Most people will tell you, I'm feeling a little faint, things like that, just normal people. But again, brain and nervous tissue need the requirements for glucose. So when people become severely hypoglycemic, they can faint, lose consciousness. They can go into seizures or convulsions. We can get brain damage. We can even get death that occurs. Typically, the diabetics are going to be taught symptoms of hypoglycemia. They learn their body to the point where they know that when they start getting hypoglycemic, there's things that they know. For example, I had a friend that was in, when I was in the, doing my postdoc, he was a pretty severe hypoglycemic, pretty severe diabetic. Basically, he learned that to pay attention that he was having either he started having aspects with the CNS about having some issues, starting to feel confusion, weakness. One of the things he would say is his heart would start speeding up. So tachycardia, headache, breaking out in a cold sweat. A lot of these are due to increases in epinephrine. So it's really a hyperadrenergic response. This is one of the reasons why we are cautious about using beta blockers in diabetics. One of the things that can happen is, for example, since this is a hyperadrenergic response, one of the issues that can occur is basically is they're looking for that autonomic response, which is a warning to tell them they need to do something. And if we give them a beta blocker, the beta blocker can block some of that. So what we see typically is a lot of them will complain of they're feeling their heartbeat, so the tachycardia, they may feel weak, vision may be a little blurred, they start feeling a little bit confused or sort of dull, breaking out into a cold sweat. These are some symptoms that they're going into hypoglycemia. So typically, an experienced diabetic will recognize these symptoms and can respond. That's when they usually go and want to get, they want to get some orange juice or something like that. Sometimes they'll carry around a glucose tablet. My buddy used to always just try to carry around a candy bar, which he would use. Fruit juice is another thing that's very common. The problem is that, again, a beta blocker may mask these symptoms. Once they get to where they're confused or mentally disoriented, they may not recognize those symptoms or put them into context with that being a problem. So that can be another thing that is there. And another thing that can be done is they give glucagon. But most people, if they're out, they start experiencing this. Usually it's getting them, the lawyer friend, the guy that I told you about, his scenario was he would, he kept jelly beans. That was his go-to thing there. But a lot of times the diabetics will carry with them some sort of, I actually don't know any that are actually carrying a glucose tablet around. Most of them I know will carry like a candy bar or some sort of high sugar glucose component with them. Like I said, jelly beans, candy bar, things like that, or will go, have orange juice or fruit juice fairly regular. Now, when somebody goes into a severe hypoglycemic state, they can go into unconsciousness. And when they are when this is occurring due to an overdose of insulin, this is known as an insulin insulin coma. We talked a little bit about this earlier this morning when we were talking about the insulin comas versus a hyperosmolar coma. Okay, so an insulin coma shouldn't be confused with a diabetic coma. Okay, diabetic comas develop over several days or weeks, so it's emerging, whereas the insulin coma develops pretty quickly in a matter of minutes. Okay, so but if you came across a person that was unconscious and you knew they were a diabetic and you weren't sure whether they had overdosed with insulin or whether they had or was just a diabetic coma, so what should you do? Well, since you don't know whether they've overdosed with insulin, if you give them insulin, that could actually make things worse and cause death. So the safest thing to do is, if you come across somebody you need and want to do something first, is you want to administer glucose. Given too much glucose is not going to hurt either one of them, but given too much insulin, if it's an insulin coma, basically this can be that would be life-threatening. Okay, let's look at a couple of other of these longer acting insulins. Some of the ones that we've come through, like I said, Humulin is a very common insulin that we see used in a lot of patients. But some of these longer acting ones, Lantus is one, which is a glargine insulin. It's designed to be a long acting insulin. And what they've done is they've taken insulin and modified it. So so again, one of the things that we may want to do is give them a long-acting insulin to sort of give us a baseline, and then when they need additional insulin, we can give them some insulin shots, such as Humulin. So what this one does is that when it's injected, what we'll have patient usually do is have these injected once a day. So they take it every once a day basis, and this gives them the baseline of insulin. And then what we will do is that if there's times when they need to supplement the insulin, we can use something like Humulin to do that. Dedamer insulin, sometimes known as Levomer. So what they did with this one here is basically they're going to take the insulin, the beta chain. You remember insulin had an alpha and beta chain. They're going to take the beta chain of the insulin, and what they do is they attach a fatty acid group to that beta chain. And by adding that lipid component there, what that does is it slows the absorption from the subcutaneous site. It'll still be absorbed. It's just going to be a slower absorption. So then once the dedamer gets in, what happens is it binds to albumin, which is a protein. That also slows its absorption to go across the endothelium of the cells. So one of the nice things about dedamer is we do get a longer duration of action, but we also see sometimes in type 2 diabetics, we are going to use some insulins in addition to, they're still making insulin, but we're going to give some insulin. We may have to supplement with insulin in some of those patients. So one of the things that with a lot of the products they use in a type 2 diabetic is actually they can cause some weight gain. And so one of the things with dedamer insulin, they can use it instead of the neutral pH insulin and have less weight gain. Now, for a long time, all we had was injection, but then we came out with Afrezza, and Afrezza is an inhaled form of insulin. One of the things that there's actually a black box on Afrezza because in patients that have pulmonary disease, chronic pulmonary disease, one of the things that can happen is inhaling the insulin can actually produce a acute bronchospasm. So that can be pretty unnerving. So as a result of that, it has been contraindicated in those patients. We can still use the other insulin, the injectable insulin, but we don't use Afrezza for that. So when we're looking at this insulin, Okay, here's our problems, is that the insulin replacement is, first of all, we can develop what is called insulin resistance. So we're replacing the insulin, but now our body starts becoming resistant. Something happens to the receptors so that basically the receptors just don't recognize or respond to the insulin. So if they become insulin resistant, basically now we may have an uncontrolled diabetic state. Since the insulin isn't working, then it's not, it's not acting on the receptors. Sometimes, as I said earlier today, it can be that there's a reduction in receptors. Sometimes the receptor number stays the same and the tissues just aren't responding. But if we can't get the insulin in there, one of the things that can happen is that we're going to have an uncontrolled diabetic state. I can give you insulin, but if your body's not responding to it, it doesn't do us any good. A lot of times we run into problems where that insulin resistance, I should have turned to tell you, is that if the diabetes is not controlled, then your body may develop insulin resistance. That's the way I was describing it was first. The insulin, so basically, if you're not controlling, if the insulin resistance occurs and we're giving insulin, it's not working. So therefore, we're going to start having consequences of diabetes. We can see sometimes acute stress increases our need for insulin, and that acute stress may flood the receptors in the body may become unreceptive. We can see that many times insulin resistance has been associated with, they believe, there's something wrong with the immune system, where the immune system actually develops antibodies to the either to the insulin or to the insulin receptor. Obesity. This is another thing that we see in type 2 diabetics a lot, is when they become obese, their tissues become resistant. And when we get insulin resistance, there's a problem, because now the insulin, even if we're producing insulin, we're not being able to use the insulin because our body is resistant to it. Another thing that can occur, so we can develop insulin resistance, which means our body doesn't respond to insulin, and therefore we start seeing consequences of diabetes. We can develop what is known as a diabetic ketoacidosis. That basically, if we don't have enough insulin there, basically we get the keto bodies formed, and people develop hyperglycemia. The insulin is not working, so what's happening is the glucose is not going across into the tissues, it's staying in the blood and elevates, so we get the hyperglycemia. We also get, without the insulin being effective, we start seeing increased lipids in the blood. So the hyperglycemia, the lipemia, can result in atherosclerosis and some of the cardiovascular changes that occur. We've seen glycosuria, so we get glucose going over into the urine, and people get dehydrated. These are all issues that can occur when we have problems replacing the insulin like we need. And as we said earlier, hypoglycemia, a lot of diabetics learn to look for the signs of this hyperadrenergic state. That is, that's a key point for hypoglycemia. So as I said, tachycardia, sweating, and being very anxious. That is probably the three most common symptoms that people identify. A lot of them say they feel the heart starting to beat up. They start feeling real restless, real edgy. Now, another thing that can happen is we can see CNS problems. So neuroglycopenia is where our neurons are not getting enough glucose. So people, again, think about the brain needing as much. It uses glucose to feed off of. So basically, what we need is that if our brain is not getting, and neurons do too, if they're not getting glucose, then they're not going to function. So we can get confusion, psychosis, seizures, coma. One of the things that you might want to do a rule out on is if you have a patient coming in with a psychotic episode, one of the big things that you might want to rule out is whether they are in a hypoglycemic state. I've even seen issues with one of the things with traffic stops where people are driving recklessly or whatever. People have pulled over and been charged with, DUI, driving under influence, and it has been a hypoglycemic response. had a case recently where that someone had a pump on, and the pump appears may have stuck and was dumping out too much insulin, and that was an issue. Even in well-controlled patients, we can sometimes see some mild episodes. In a well-controlled patient, there may be instances that can occur during the day that may produce this hypoglycemia. So just because someone is very compliant and everything doesn't rule out that some of these episodes, they're not usually nowhere near what we would see with someone who's uncontrolled, but this can occur. And then, as I said earlier, is we want to be careful because beta and blockers can basically reduce these symptoms. They can also block gluconeogenesis and glycogenolysis. So beta blockers we have to be very, very careful for. Another thing that can happen is we can get a rebound hyperglycemia. So when they recover, is they go from the hypo to maybe the hyperglycemic effects. People have developed allergies to insulin. Typically, this occurs with either denatured insulin or protamines or zinc sensitivity. So they can be allergic to the protamine. Some people may be allergic to zinc. We do see that we can get some what is called lipohypertrophy, where basically insulin itself causes production of lipids. On the other hand, we can sometimes get just the opposite, which is lipoatrophy, where the fat in the tissues sort of recedes. That typically is secondary to a contaminant. And another big thing that can occur is we get what is called insulin-induced edema. And what happens here is that your body retains sodium, and so that makes you retain fluid, and the capillaries become a little bit more permeable, so you get more fluid leaking in the capillaries to form the edema. So even when we are treating patients well, we can still have some problems with this. Okay, let's take our next break. This will be our last break this morning, and then I'm going to come back and talk about glucagon, and then we'll talk about, finish up before lunch, the other drugs that are used to treat diabetics. So let's come back at 5 after the hour, okay? Melissa, I reset that test. Did you get the post-test? Marissa, that was what I was referring to. I saw I'd muted before I had left there, but yeah, that was the post test. And so just so that you know, is that we're going to go probably about another 20, 25 minutes, and then you can put up the questions for this morning. We'll put those up and let them break for lunch with regard to that. Okay. Let's say. All right, guys, let's go ahead and get going back and cover the last part of a little bit about the last part of diabetes here. So another compound that is formed in the pancreas is glucagon, and this one is actually what we. Sure, I got this on the right slide here. There we go. So it's formed in the pancreatic alpha cells. Make sure you differentiate between those. The beta cells are for insulin. The alpha cells are basically for glucagon. Okay, so glucagon is sort of the antagonist, or has the antagonistic actions for insulin. So what we find is that when glucose goes up, that actually inhibits glucagon secretion, and the glucagon can increase cyclic AMP in different tissues, and basically it's going to inhibit glycogen synthesis and so forth. So what we use glucagon for primarily is to treat insulin-induced hypoglycemia. So we can use glucagon instead of using glucose. Now we can give this parenterally, so this can be a much faster acting agent, but a lot of times we can control or make the change or antagonize the effects of insulin by using the hypoglycemia by just increasing the glucose intake, which is what we can normally do. Okay, so glucagon made by the pancreas. We also have this as a drug. We can give it parenterally and use it to basically treat hypoglycemia. So a question that I could ask you would be something along the lines of, to treat hypoglycemia, insulin-induced hypoglycemia, which drug is used? And the answer would be glucagon. Okay. All right. Now, with insulin, primarily insulin is being used a lot in individuals that are insulin deficient. So, but we do see that in patients that are the type 2 or the insulin independent, those individuals are basically making insulin, but there are times that we may need to use insulin with those two to sort of supplement. But majority of what we're going to do is we're going to use other drugs that are used more for these type 2 diabetics. Now, these drugs here, the ones we're going to talk about, the sulfonylureas and some of the others, they all require a functional pancreas. Okay, there has to be. These drugs are basically they're not replacing insulin, but they're going to affect it. So these drugs will not work if the body's not producing insulin. Okay, so one of the things we start off with is a group of drug called sulfonylureas. Okay. They were actually discovered accidentally when people were looking at trying to develop sulfa antibiotics. And what they discovered was that in trying to look at these sulfa antibiotics, some of these basically dropped blood glucose. They developed a hypoglycemia. And so then they started being developed as anti-diabetic agents. And we've seen they've gone through a couple of generations of those. Again, typically it's not uncommon for a drug company to find an initial drug they call the first generation. That initial drugs or drugs basically may have several issues associated with either toxicity or its pharmacokinetics may not be optimal. So what they do is they try to alter the structure so that we can get either a drug with better pharmacokinetics or maybe one that has a better safety profile. So that's occurred. Sometimes the drug may not be, the first generation may not be real potent, so subsequent generations may also increase potency. So with the first generation, we saw some drugs called tolbutamide, tolazolamide, acetohexamide. Some of those are still around. Then we went to the second generation, which are glyburide, glipizide, glicazidide, and rosiglitazone. Now, several of these drugs have been in the media because there's been some lawsuits with regard to some of the actions with these drugs, and so those have been some issues that have come up. But let's just talk about in general these sulfonylureas. So here's why the pancreas is necessary, a functional pancreas is necessary, is they promote insulin release, okay, from the beta cells. So the sulfonylureas, if your beta cells aren't making insulin or your beta cells are completely deficient or dysfunctional, these drugs won't work. What's happened in these individuals that we're using these drugs on is that there has been, their insulin levels may actually be close to normal and maybe just slightly low. But the reality of it is that they are producing insulin. What these drugs probably do that is the reason they work a lot for these insulin independent diabetics, the type 2 diabetics, is because what they do is increase insulin sensitivity. Many of these individuals, what has occurred is basically that their body or their tissues have become insulin resistant. So the idea is insulin is being produced, but the insulin is not producing any effects because of this insulin resistance. So a big part of what these drugs are doing is basically they are making the tissues sensitive to the insulin. That's their big thing there. They're absorbed pretty, we don't have to worry about injecting these. They have good absorption from the GI tract and almost completely absorbed. Some of them do bind to plasma proteins, and so we may have drug interactions there. But again, these require the presence of insulin, okay, either circulating or in the beta cells that can be released. These are not effective. These drugs are ineffective in treating insulin-dependent diabetes because I keep saying independent, insulin-dependent diabetes. In the insulin-dependent diabetes, what's happened is the beta cells are damaged or are not producing insulin. You have low insulin levels. If these drugs are given, they try to stimulate the beta cells, but the beta cells aren't functional. So these aren't used for the insulin-dependent diabetics. That several of these drugs have a numerous types of side effects that have kicked around, and the incidence of the side effects have ranged anywhere from 3 to 66% of the patients. This is of all side effects, and so it's one thing that we have to watch, which is one reason why sometimes we have a compliance effect. What we do see sometimes is the most frequent complication as far as a side effect is hypoglycemia. So what happens is that basically someone has either overdosed, they gave themselves, took too much of a dose, or too much was prescribed. Another thing would be is that as the disease has changed, that sometimes what's happened is the insulin sensitivity has changed, so that suddenly, sometimes we know that exercise and diet, those type of lifestyle changes can alter insulin sensitivity. And if someone is being compliant with diet and so forth, sometimes we may get that these drugs are, that they increase their, or actually decrease their insulin resistance, and then these drugs add to it, and we may get some hypoglycemia. Change in dietary pattern, so going on diets, binge eating, things like that could, fasting could create a problem. Another thing is altering energy expenditure, suddenly going out and running a marathon, or start working out, CrossFit or whatever, 3, 4, 5 times a week. So what we do is we treat the hypoglycemia usually by giving glucose injections. If it gets severe, sometimes this can last for several days, even after we stop the drug. But it's something we need to, that we would watch by monitoring their blood glucose. The first generation, I've told you there, they a big concern of them was protein binding and drug interactions. Those first generations, we saw people complain of GI disturbances, nausea, vomiting, some diarrhea, sometimes constipation, not an uncommon type thing with orally administered drugs. Did see some allergic reactions, did see some dermatological problems, and in a small number of patients, when I say dermatological, some minor rashes. And we did see some leukopenia, so a decrease in white blood cell in a small number of patients, but those, it was usually transient, and basically the patient recovered. Let's see. Joy, you ask a question. Can you manipulate these the same way that insulin can be manipulated to cause um, diabulimia? In other words, can you use these to, in some of these individuals that are doing some purging and things like that? I would say it's a possibility, but I'm not sure. I'll see if I can find something on that. All right. This class, you guys have come up with some very interesting questions. It's been interesting for me from some of your experiences and patients that you've dealt with, and I enjoy that from a standpoint of getting these type of questions. Is sort of new. It sort of lets me learn from you guys some too. One of the things we see is we don't want people drinking. We sometimes get a flushing reaction. They turn real red. Face feels like it's burning. That occurs with chlorpropamide. We also can get, with chlorpropamide, we get some fluid retention. That's one thing that chlorpropamide people didn't like very well, is this flushing if they drank, and fluid retention made them sort of bloated. Typically, we don't want to use these if there's hepatic or renal insufficiency. A lot of times this is contraindicated, but if we can't find another drug, then we just have to monitor them very closely. Another drug, repaglinide, this is what is referred to as a insulinotropic agent. This one in particular is actually used to stimulate insulin secretion. So it's primarily going to, just like the other drugs, it's going to require insulin to be present. So most of them can have some insulin. So we do see this is this causes the beta cells to release insulin. So when we have insulin resistance, one of the things that you may have is, by increasing the insulin levels, you can sometimes get somewhat of a response. This drug has been used for the treatment of type 2 diabetes. Most of these we're talking about is type 2 diabetes. This one acts pretty quickly, but it doesn't last long. So it's got a very short duration. One of the things it also does is it can affect potassium channels. So there may be some other actions that may be a concern down the road. This one, we've seen hyperglycemia and hypoglycemia, depending on where it's at. Our biggest concern with this one is that there's an interaction with cytochrome P2C8, not a common one that we see, but definitely 3A4. But we have to be careful with this one, because that these drug interactions can elevate this level, and we can get some pretty severe hypoglycemia, even to the point of where they go into a coma. So one of the things that we see is that these drug interactions, pretty much any that go through 3A4, we want to be careful about. The conazole, these are very common drugs used for infections, for especially like urinary tract infections and so forth. If you see conazole, when we talk about antibiotics, I'll reemphasize this to you. If you see the conazole on the end of these antibiotics, just in your mind be thinking drug interaction, okay? Monoamine oxidase inhibitors, there's an interaction that can occur there. But we need to make sure when this drug is being used, there is a big concern with regard to the potential for drug interaction. Now, this has become one of the go-to agents, which is metformin. Okay, now, this one, we find that one of the big things it does is it seems to be very effective in increasing the tissue sensitivity to insulin. So remember, in the type 2 diabetics, they're usually making the insulin, but typically they may not be making quite as much as they need, or they've got insulin resistance. So the big thing about metformin is that a lot of times this can increase the tissue sensitivity to insulin. Sometimes we'll use another one that we may do a combination therapy where we use another drug that does more of that also has a increased release or an insulinotropic effect to not only increase the sensitivity, but also to increase the output of insulin a little bit more. This one also will increase the synthesis of muscle glycogen. And the other thing about this one is that a lot of people have used this when people have refractory obesity secondary to the diabetes, that this one works pretty well. Side effects, a lot of people complained initially when this came out with regard to side effects. Most common thing is that we see nausea, a little bit of diarrhea, some gas. Those are tolerable, but can be bothersome. Can be especially bothersome if somebody's going to be doing this, taking chronic therapy. But we do see that in patients that may have renal or kidney problems, we have to be a little cautious from a standpoint of them potentially developing lactic acidosis. So if we do have somebody that has liver or kidney dysfunction, we just need to be cognizant of that. The nice thing about this is where these other drugs may produce pretty significant hypoglycemia, this drug doesn't. And the reason for it is because it doesn't stimulate insulin secretion. It seems to, if we need that, we can add one of these other drugs in a low dose to stimulate that. But most of these patients are putting out enough insulin. It's just a matter of their tissues aren't responding. We have to be careful with this drug. If somebody is an alcoholic and abusing or has a chronic alcohol problem, severe congestive heart failure, we've had some problems with metformin. So these are some very important, metformin, what happened is metformin came out some time ago. There was a bunch of other drugs that came out, and metformin, people it was an older drug, and basically people got around from it. The biggest issue with metformin is it actually works pretty well. It's not as sexy as some of the other drugs. It's a little older drug, but it actually does. And there is a black box warning on it. And the biggest thing is that patients have developed lactic acidosis. And this black box warning scared a lot of people away from this. And typically, we saw that there were specific things that put them at risk for this. So from a standpoint of this, the metformin actually is a pretty good drug, and we see it sort of as the go-to drug. Again, if we do need to have a little bit more insulin done, we can add one of these other drugs that has insulinotropic effects. Now here's a drug. Let me see something real quick. Yeah. So I was just seeing what we're at too, because I wanted to finish up these before we broke for lunch, so we're in good case. So exenatide is actually a glucagon type peptide. It's marketed as Byetta. So what it does is it basically does a couple of things. One, it's glucagon type peptide, but it actually suppresses glucagon secretion. And remember, glucagon can antagonize the effects of insulin. So one of the things it does, if we have a patient that there's a little extra glucagon there, this can suppress it. And it actually will enhance the secretion of insulin. So when glucose is in the blood, that is a stimulus for insulin to be released. And this sort of does that. And what we find is that when you look at the parameters such as fasting and postprandial glucose concentrations, it actually seems to improve the glycemic control as indicated by those type of things. Biggest concern is that, especially if you use it with a sulfonylurea, you have to worry about hypoglycemia, so you have to watch that. Some GI disturbances, but really not that bad of a problem. Then we went to another group of drugs here that, these are called DPP-4 inhibitors, dipeptidyl peptidase 4 inhibitors, Januvia, which is sitagliptin. And so what DTP-4 is a substance that actually increases insulin and decreases glucagon secretion. So basically, you're getting the insulin without getting glucagon kicked in. This one we find basically has been added. They use it sometimes on other drugs, but they will use it sometimes for trying to, when it's used, they want diet and exercise to be used with this, as we do with all these drugs. Not effective in type 1 because, again, since part of its action is to increase insulin secretion, type 1 is not secreting insulin. What we've seen with this one has been sort of interesting. There's been a few respiratory tract infections, some inflammation of the nasopharyngeal area, and some people have complained of headache. That's been the main issues with these type of drugs here. But Januvia, it's been used. Another drug that's been used occasionally is acarbose. This one basically you take before a meal, and what it does is it slows down or inhibits your carbohydrate absorption. So this is another way, sort of a carbohydrate blocker. We have fat blockers. This one sort of focuses on carbohydrates. And so this one has been used sometimes to cut down on the amount of carbohydrates taken in, which ultimately will affect glucose control. Now, there's the glitazones. The glitazones are another group of drugs. Again, several of these have been used. Several of these have had lawsuits associated with them. A lot of these, when these came out, a lot of people were moving away from metformin. People have now moved back to metformin. So what these drugs do is basically, only for type 2 diabetics, they are insulin resistance reducers. So the idea here is insulin resistance is the main problem. So these drugs basically improve the sensitivity of the cells to insulin. And these particularly seem to work in the fat and the skeletal muscle, which is where a lot of which are two big target cell responses. We see they can affect the metabolism of fatty acids, which is good. Another thing they do, they seem to take the glucose transporters, move them to the cell surface, and when you do that, that seems to improve the effects of insulin. So what they basically are doing is making the cells more receptive to insulin and increasing the glucose uptake. Most of these will bind to what is called the peroxisome proliferator activated receptors. These are called PPAR, and we use that acronym quite frequently because it's difficult to say, peroxisome proliferator. Again, these are effective only in the presence of insulin. Now, let me throw in something a little bit different here. Something to think about is that we've been talking about that these drugs, that you have to make it, that there has to be endogenous insulin. But we found that these drugs also will improve if it's exogenously administered. So sometimes in these patients, what we find is we can get some glucose control by these type 2 diabetics taking an insulin preparation, and using these drugs will help the insulin get into the cell. Whereas the other drugs primarily were focused on endogenous, this group of drugs will actually improve the uptake or improve the effects of insulin that's given along with it. Type 2 diabetics, again, main thing, the biggest thing is these can potentially be hepatotoxic. There was a drug called triglitazone. It actually was pulled off the market because of hepatotoxicity. The newer agents basically they have a lower toxicity, but they still have a black box with that, with the warning on them. So it is, let's see what rosiglitazone. A lot of times say these agents may be used in combination. In fact, there's combination products with metformin with these. So rosiglitazone was at Avandia, and Avandia has got a black box warning that can cause congestive heart failure. So several of these drugs may still have black boxes. Main things usually with these newer ones have been cardiovascular complications that have been identified. Congestive heart failure is the big one. Now, again, when we're looking at these glucose control, we're looking at diabetics in general. It's hard to do, as I've said over and over today already. It's very difficult to get control of blood glucose with a fixed concentration of insulin. Your insulin concentrations will fluctuate throughout the day. Sometimes they can even fluctuate quite a bit even within hours. Insulin requirements going to be affected by exercise that can alter your insulin sensitivity, stress, pregnancy, steroids, other drugs, thiazides, several things can alter the insulin sensitivity. So it can be drug induced, it can be activity and so forth. Makes it extremely difficult for us to do that. So that's one of our biggest issues, is that basically in trying to get control is that it's very difficult to do it, which gets patients frustrated, and they can have some pretty strong consequences. Also, the drugs basically that you're using, one of the reasons we want to push compliance is not only for dealing with the diabetes, is because by keeping compliance, we can typically keep the dosage of these drugs down, especially if we're doing exercise and diet and so forth. Those type of things could keep our doses down, and by keeping our doses down, that can avoid some of these side effects. But we have to be aware. The nice thing can be is that with diabetics is they do need more monitoring. If you can get the patient where they're coming in and being compliant so that you can monitor them, you can have good success. But we do have a lot of, as indicated when I asked you guys earlier, we do have a lot of patients who have just not been compliant for whatever reason. Teenagers seem to be a problem of thinking they're immortal, or that they're young and don't want to be different. Older people, it may be being able to get to the doctor, or they're just getting fed up with it and tired of doing it, or cost. There's a lot of different issues, but diabetes is a whole subject in itself with regard to managing those. Okay, so we are at the end of this morning's session. Marissa's going to put up the little short pre-quiz or short question quiz for this morning. I've also may have covered a couple of things we touched on yesterday. Don't worry about it. Answer them the best you can. When we come back from lunch, which I will see you guys at 1 o'clock, basically what we plan to do is I'll go over the short 4 questions. And then this afternoon, we're going to spend the rest of the day basically talking about anticonvulsants. So anybody have any questions before we go? All right. You guys have a good lunch. And Marissa, if you'll go ahead and put those questions up. And I think, Marissa, you've already taken attendance, if I'm not mistaken. But if you haven't, go ahead and do that. Okay. I will see you guys at 1 o'clock. You have a good lunch.